Good morning. And I'd like to thank the organizers for inviting me over. It's more or less a 7-8 hour trip from Manila, but it's all worth it because we've been enjoying your beautiful city and the hospitality of your people. I'd like to thank Dr. Ganical for making my talk easy. So I'm just going to try to fill in and give our own our management and diagnostic regimen for this urgent situation. Right? Because when a patient comes to you the following day, you did perfect surgery, and the patient comes to you looking like this, then your heart practically stops beating because although rare, you can have these very problematic cases. So this is my own case. We did a flax or femtosecond cataract surgery, perfect, no problems during intra-op, and she followed up the next day saying, "Doctor, I couldn't see well, a little pain, discomfort," and you sit her on the slit lamp and she looks like this. So then the question is, like Dr. Ganical says, is this infection or is this severe inflammation? So that's what you have to do to differentiate. Okay, so this is how we do it and go about it. Now, TASS, remember there was an outbreak in the US, and this was recorded and published. Fortunately, it doesn't occur too frequently nowadays, but you should always be aware that it can happen because of sometimes wrong sterilizing techniques, OT preparation. You know, you're not very aware about how you sterilize your equipment, especially the accumulation of fluid in your sterilizers, which can harbor toxins, and then bring them onto your instruments for surgery, and you're actually transferring toxins into the eye and causing TASS. It's very important to realize this and to prevent TASS from happening because it can have very severe permanent damage. And as mentioned earlier, you can have very problematic problems like glaucoma and a severe corneal decompensation, which would require corneal transplant. Now, when we go through the process, the mental process of differentiating infection and in severe inflammation, this was already shown, and these are more or less the characteristics and features of both, and will help you differentiate between infection and inflammation. And as you can see, pain is there, but it's really not a very differentiating, a very reliable differentiating factor. One of the things we look for, of course, is the type of corneal edema. TASS would have a more severe white-to-white or diffuse corneal edema, whereas endophthalmitis would be more or less localized close to the incision. But what you really have to look for is the vitritis. So as mentioned earlier, you dilate the patient in your clinic, have her seated down comfortably, apply your dilators. You can start a steroid challenge as well because you have to deal with the inflammation, whether it's an infection or pure inflammation. So that's the response to the steroid. So you probably have to have the patient there in your waiting room for about 2 hours or 3 hours just for observation. If you can't dilate the pupil very well because of the fibrin, you can have a pupillary membrane, that's severe reaction. Or if for example, there's a very poor view of the vitreous, then you may have to go through ultrasound and do your B scans and determine whether you have a vitreous reaction, because once you have a vitreous reaction, then that's infection. TASS rarely has a severe vitreous reaction. So once you see that, then you have to admit that patient and treat as an endophthalmitis. So this is what we do. We do apply a topical steroid challenge. We dilate the pupils. We are aggressive with the antibiotics. And we observe the patient for at least 2 to 3 hours. Remember, if there's any doubt, you have to treat for the worst situation, which is infection. And that's why we're also aggressive with the antibiotics. This is just a sample of the ultrasound, the B scan. And this definitely would be an infectious cases or an endophthalmitis. Okay, so once we're set with our diagnosis, we have to admit the patient and start with our IV antibiotics, intravitreal antibiotics, and all all the things that we need to do to control the infection. Now, just a quick overview on the possible causes, which was already mentioned earlier. Anything that we inject into the eye can cause TASS. Improper sterilization techniques can also cause TASS. Contaminants during the surgery on our instruments and our irrigation fluids. And of course, the real culprit here are the endotoxins, most likely, that seem to contaminate our surgical instruments during our sterilization process, all because we failed to really clean our sterile equipment and our sterilizers well, and drain those fluids that accumulate underneath, which harbor the endotoxins. Although they kill the organisms release the endotoxins. They accumulate on in the fluid, and so when you re-sterilize your instruments, those endotoxins get stuck to or contaminate your surgical instruments. So what do? This is a long document that really helps us and guides us as far as our sterilization requirements for our OTs. And this has become a problem. TASS has become a problem because of the short cycle or flash sterilization. So there are guidelines to that. You can go over this document, and there are 3 critical steps: the cleaning and contamination that you have to adhere to in this document, the sterilization techniques, and how to store your instruments so you don't get into this trouble of TASS or endophthalmitis. So in summary, early diagnosis is key. So you have to see the patient the next day. We know the risk for endophthalmitis, diabetics for one, as Dr. Prasad mentioned earlier. So we have to be very aggressive in preparing these patients for surgery and following them up. We have the NSAIDs, we have the topical antibiotics, we even give intracameral antibiotics during the surgery. We have to see the patients the next day because we need to catch these problems early and treat them. We have to differentiate. This is inflammation, infection, and we've gone through a short way of how to differentiate between the two. And of course, treat the worser condition if in doubt. You have to train your staff in the OT. You have to train your staff in your clinics to be able to help you detect these problems. And usually the patients will call up the night before they're supposed to see you the next day and say, "Doc, I'm not seeing well." Especially if it's a second eye, they say, "Doc, this eye you did yesterday or earlier today isn't seeing as clear as the first eye that you did, so there must be some problem." And you really have to be on top of this situation. Sometimes they'll call your secretary and tell her about the problem, and you need to really educate them on the possibilities and how to be able to tell you and to warn you that you have to be able to see and manage these patients right away. So the whole staff is important in really getting on top of these very urgent conditions. Thank you very much.